person-centered plans. And that entails talking first about trauma, and that part's a little bit technical. And I absolutely realize I'm a fast presenter, I'm a fast talker, I'm Cajun, and we tend to really get flying. But I'm going to go a little bit slower than I typically do in that, just to make sure that you have the basics and the details that you need to understand. And we start with the brain. We start with what happens with trauma to bodies and brains, because it's really helpful in understanding how that impacts what people do, so their responses to trauma. I am Tanya Richmond. I am a partner with Support Development Associates, which is headquartered in Annapolis, Maryland. And I have a couple partners there who also do person-centered practices. You're probably familiar with Bob Sattler, who has spent a lot of time with you in DC. It's been some time since I've been there in person, and I worked more with provider agencies there. I am in Greensboro, North Carolina, which is where I live, and it is a gorgeous spring day here. I hope you're having pretty weather too. In fact, you're not too far from me, really, and our weather tends to be pretty similar. That's kind of the details about who I am and where I am. I'm a clinical social worker by training and have been for more than 30 years now. And I told someone last week I was a clinical social worker by nature and started laughing. I'm like, no, actually, that's probably more right than a clinical social worker by training. But I have worked in the field, started with older adults, and have moved on now to work really across the age span with people in all kinds of situations and circumstances, but all focused on using person-centered practices, either with people individually or with systems or with organizations. So that's why I come to be here. I'm also the chair of the Learning Community for Person-Centered Practices for not much longer. I get done in July. So I've been on the board for a good long time, and just really am very proud of the community. Hope that if you have not checked out what's going on at the Learning Community, that you will. There's a lot of resources there for you, and I'll tell you a little bit more about that at some point during the training today. So let's get started talking about trauma and what it is. If you have not turned off your microphone, if your microphone is hot, would you mind go ahead and turn that off so that we can't hear you? And Debbie will keep an eye on that. With me today is Debbie Paul, who is the administrative assistant or the administrative manager at Support Development Associates, and she's going to be watching in the chat, letting me know what's going on, and also just handling all the behind the scenes logistics. She's the one who helped you get registered and et cetera, et cetera. So she's a great support to me and just a real gift to the world. So trauma is what our topic is today, but we're going to talk about specifically trauma and why we need to make room for it and really consider it in person-centered plans. And trauma is one of those words that's a buzzword lately. If you get stuck in traffic for more than 15 minutes, you've been traumatized. We all use that word all the time. But truly, we're going to talk about what is real trauma, what causes trauma, and what are the responses to it, what happens in our bodies and our brains. And we think of it, what it really, its definition is as a response to something that is deeply distressing to a person or a disturbing event that they might have experienced. And whatever that thing is, whether it is little t trauma, which we'll talk about in a minute, or big T trauma, which we'll also talk about, it overwhelms how a person copes, and it causes them to feel helpless, and it may diminish their sense of self or their sense of their ability to feel the full range of emotions that we typically would feel, or have the full range of experiences that they typically would have. And the symptoms of trauma can look very dramatic. If you have experienced trauma yourself, and I would argue, although a lot of experts say it's not true, I would argue that we all went through a shared trauma for the last few years as the pandemic has kind of raged on across our country. I would say the more horrific effects of it, or the more horrific immediate impacts of it, are dying down, but people are still getting COVID, and we're still reminded daily of the people who are not with us and the changes to daily life as we know it. And in some cases, we have weathered that, we've adapted to it, and we've moved on with life. Remembering, though, however, that we've been experiencing trauma in the last few years, but for others, the symptoms can be more dramatic and long lasting. I will tell you that I've been doing therapy online since about the middle of the first year of the pandemic, just because I really felt like there was a huge exodus of therapists from the field. I'll tell you a little bit more about that later as well. Clinical mental health therapist, and people were really suffering. And every person I was talking to was explaining some form of grief, some form of loss, whether or not they had lost a person in their life or persons in their life. They may have lost a situation that they liked, a job that they liked. All kinds of things that happened were not the loss of people, but they represented loss. So what I noticed was lots of folks were grieving, and that's an area of specialty for me. So I really wanted to offer what I could to be of assistance. But in addition to that, what always happens when we have something like a pandemic, and we haven't had any of those in our recent memory, except the one that we all went through, is that the issues that people experience actually follow the event. So depression, alcoholism, all the things that might result in, behavior that needs attention from a therapist, or psychological manifestations that may need assistance from a therapist, happen actually after the event is over. So the symptoms of trauma can be really dramatic, and they can also be extremely subtle, extremely hard to notice, like a persistent mild stomach ache or a general feeling of unease. And that's what a lot of people describe to me as, like, I'm kind of waiting for what's next, the other shoe to drop feeling. Some folks will describe it as. So trauma often manifests not just psychologically, but it may also manifest for some people emotionally or mentally. And some common physical signs of trauma, things you might see or even notice in your own body. And I promise we're not going to talk about you the whole time or me the whole time, but you probably have had enough of this in your recent history that it will resonate with you. Physically, you might experience things like lethargy or fatigue, or maybe having a hard time concentrating, or having a racing heartbeat. Even things like being pale, being blanched looking, might be a part of kind of that low level ongoing exposure to trauma and your physical response to it. And the person who is experiencing trauma may also have something that kind of looks like an experience of trauma. So they might have anxiety attacks or panic attacks, things that we could actually notice and be unable to cope. So really see their coping mechanisms overwhelmed. So when we talk about trauma for our purposes today, what we're talking about is the response to a series of events, the response to an event itself, or to something that the person has experienced. And it could be either physical or emotional. And it usually has some kind of impact on the way the person functions. And I will talk about some exceptions to that as we spend time together today as well. And the functioning I'm talking about is mental health functioning, physical functioning, social functioning, emotional functioning, or spiritual well-being. So it can be very pervasive, and it can kind of fit into a lot of categories. I'm taking a peek in chat, just seeing what's going on there, see if anybody, yes, so folks are saying they're about other traumas that we've experienced. Yes, not just the pandemic. We certainly did go through, as a nation, the witnessing of the trauma that happened with George Floyd and many others. There's lots of stuff that has happened in the last 2 or 3 years that we're all just very aware of, that we may have a traumatic experience too. I would say even as late as this week, maybe yesterday, something's happened. And I think, and not to get into all the details of current events, because we all know that we would spiral quickly and would be in a very bad spot together, right? But absolutely, these things are around us all the time. We have more access to information than we've ever had in our history, and that can be very overwhelming. So it's not a wonder that many of us are experiencing the effects of trauma. So let me give you a few trauma basics and what it is and what happens when we're experiencing trauma. And I'm going to talk about it in two ways. I'm going to talk about it from the individual perspective. So what happens to people. I'm also going to talk about what we need to know from a systems perspective. And I picked systems to talk about in particular, and I am talking about your system of serving and supporting people, because part of what systems need to learn to do, this is my opinion, but it's also the opinion of many people who work in our field, is accommodate trauma in the way we plan with people. So from a systems perspective, there's some things that are helpful for us to know as well. So when we talk about trauma, I think of it in kind of two categories. Now, this is not my original thinking. There's a lot of researchers out there who talk about this. A lot of what I've learned about trauma, if you all have seen Dr. Karen Harvey present, Karen is a friend and also just a trusted colleague. And I've learned a lot about what I've learned from trauma, either from her or from sources that she's pointed me to. So there is a body of research out there, but Karen may be one of the foremost practitioners of working with people who have experienced trauma who also have IDD, which is in our field. Not all of you work with people who have IDD, but many of you do. So you may know her work. She's she's close to you. She's in Baltimore. And she's one of the most trusted experts in the field. But there are two main categories of trauma. And the first would be kind of the big T trauma. And that's the stuff that all of us would agree, like that would be traumatic if that happened to me, if that happened to anyone. And big T traumas are the ones that are most commonly associated with post-traumatic stress disorder or PTSD. And it's things like you would expect: serious injury, sexual violence, life-threatening experiences, abuse, neglect, whether it's physical abuse, emotional abuse, those kinds of things. So threats that are serious in terms of physical injury, death, sexual violence, that can all cause an intense trauma to a person, even if the person is never physically harmed. And we will talk about vicarious or secondary trauma in this training as well. So people who witness big T trauma events are people who are living and working like you in proximity to trauma, are also vulnerable to post-traumatic stress disorder, especially those who encounter things like emotional shock on a regular basis. So paramedics are a prime example. Social workers, those of us who are in helping professions, prime examples of people who carry huge trauma loads vicariously for other people. Therapists, police officers, and you can name many more, nurses, I'm sure, depending on the field that they work in. The example on the screen here is the loss of a person. So loss, grief, may also be a traumatic event for people. So it could be if you think about our field and what we do for work, and I know that many of us are from different backgrounds or we're working with different populations, but we might lose the people we love. We might lose the people we live with, and we may lose the people we work with. And so as I've worked with provider agencies over the last couple of years, we're seeing trauma responses in staff actually losing either their colleagues or the people they've supported. We're seeing trauma responses in the people supported because the person they lived with went to the hospital and never came back. So at that time, what we were noticing, and this is really related to the pandemic, is we weren't really able to engage in some of those collective rituals that we have to help us get through those hard times. So grieving was something that was really stunted. This is just one example of a big T trauma, but just to give you an idea of what could happen. Additionally, we might see traumas we call little T traumas. Little T traumas are things that are highly distressing. And let me click these in. If you know me, animated slides are my kryptonite, so I have to click them in so I can just talk about what's there. I don't see the point of them, but I actually developed this one and I'm like, why did I do that to myself? And I also see that my wording is a little askew there on this particular version. But little t traumas are things that affect us on a personal level, but they don't fall into that big T category. So we might have a hard time understanding why someone's responding the way they are to maybe an event or something. I think of little t trauma, I actually kind of call it slow drip trauma. It's like getting a little dose of it kind of on a regular basis. So slow drip, as if you were taking it from an IV maybe. So they don't fall into the category of the big T traumas. And it could be things like, for example, maybe non-life-threatening injuries. Emotional abuse sometimes falls into the little T area. Your pet passing away. For some people, they might say that's a big T trauma. And I'm not trying to judge whose trauma is bigger than the other. I'm just trying to give you some examples to think about. Bullying or harassment. And if you think about the field we work in, whether you work with someone who has mental health concerns or someone who has a disability, bullying is a huge part. It's a huge part of our culture, actually, but it's a huge part of the experiences that people who have disabilities and vulnerabilities may experience. So imagine being bullied over the course of your life and what a slow drip of trauma that would be over time. And certainly some losses of significant relationships. Some of those may rise to the occasion of big T, some may be smaller. We as human beings have really unique capacities, really marvelous capacities, actually. Our brains can do remarkable healing. And we will talk just very briefly about post-traumatic growth, because I think that's an important part of us having hope about what happens when we talk about trauma. But we have really unique capacities to handle stress, and we call that resilience. So it's how do we get past things? How do we rebound or be resilient to what we experience? And that impacts our ability to cope with trauma. So what's highly distressing to me may not actually cause the same emotional response in someone else. So for example, I could be exposed to something that I find completely overwhelming for my coping system, but Grace, on the other hand, might not really have much of an impact at all from that same event. So it's the key to understanding what constitutes little T trauma is to really to examine how it impacts the person individually rather than focusing on the thing itself. So some of you might, and I hate to use anything that might be triggering, but you might lose a family member. You might lose a family member to death. And for you, that would be an overwhelming experience. And the grief from that would be overwhelming for your coping system. The trauma response to that would be remarkably big. And it would just make you feel completely overwhelmed and out of sorts. For others of you, you might lose a family member and just continue to function and go on. You might feel sad, which is appropriate. You might actually feel grief, which is appropriate. And you may also feel not much else. So it really is dependent on the individual. And a lot of times what makes the difference and how we kind of determine whether this is a big T or little T trauma is that often the little T traumas don't necessarily meet the criteria for post-traumatic stress disorder diagnoses. And even though those events can be extremely upsetting and cause maybe some significant emotional damage, particularly if a person experiences more than one event of these traumas over, different periods of their life or different periods of their development in their life, like early childhood or adolescence. But there's a lot of evidence that says that repeated exposure to the little T traumas, that slow drip trauma, can really cause a lot more emotional harm than exposure to one big traumatic event. So exposure to one big T event. And empathy and acceptance, that becomes our job then as we plan with people, as we engage with people and support people for the impact of little T traumas. And that can really be harder for the person who's experienced it to garner because it's not always intuitive for us why they're responding the way they are. Or there's a misconception that those little t traumas are less significant. And that's why I said I'm not judging, whose trauma is bigger. I'm not saying your trauma is a big T trauma or a little t trauma, but it really can be hard to understand why someone responds with the intensity they do to some of the things that you might witness in terms of trauma. And it may seem less significant because maybe it's not life threatening. And you think, well, okay, they're okay. Why are they behaving that way? But when we minimize the impact of the little t incidents, that can really create adverse coping behaviors. And it might be things like people start to bottle up their emotions, or they attempt to manage the symptoms themselves with whatever way. It could be with alcohol, it could be with some behavioral response. And often what we see as a behavioral response may actually be some post-traumatic responses or some trauma, being triggered by something that's been traumatizing. And if we fail to address the emotional suffering of any traumatic event, that can really lead to cumulative damage over time. So little t traumas, one of the things that we might expect a person to do in response to them is isolate. We might see them start to kind of freeze or not be able to predict what's going to happen. So anxiety usually comes along with that. And loss of a sense of purpose or satisfaction. So those are some common, and they don't seem quite as dramatic as the response to a big T trauma either. So they're harder for us as professionals sometimes to understand, what do we do with that? How do we plan around that? With someone, again, these are some of the things that Dr. Karen Harvey shared with me. This is certainly in lots of different research. A lot of her research comes from Vessel van der Kolk. She often presents with me here in DC, by the way. She just was not available for this series. But some of the symptoms that we would see with post-traumatic stress disorder, 4 big categories for that. So the reason I want to share this with you, even though this is a little bit on the sciencey side, we've tried to make it as easy as possible. And the reason I think it's important that is that sometimes what we see and think, that's a behavior. This person is, we use the term having a behavior, right? And we want to do something about that. It's linked to something. So it's really linked to something they're experiencing. And when you think about it from the experience of trauma, they're actually re-experiencing often. So that's that first category there. And it would be anything that interferes with the present that the person is in to different degrees. Things like intrusive memories. So remembering what happened and really not being able to put that out of your mind, or nightmares, or, sort of like when we're at our most vulnerable is when we're asleep and it preys on our brain. Or flashbacks. The person can't necessarily disconnect from the reality right now and or be convinced that they're not being attacked right at this moment or threatened because the memory is present as if it's happening right now. So we would call that re-experiencing. The second big symptom that we might see is around avoidance. So blunted emotions, shut down responses, maybe the person becoming obsessive about details concerning their safety or, the safety of others around them. I remember during the early part of the pandemic, we were doing all kinds of things, and you may still be doing this. I'm not judging this in any way, but wiping our groceries down with Clorox wipes. I was sunning my mail in a basket in the front hallway in my house. It's very sunny, thinking somehow magically sunlight was going to kill germs. So I would just let my mail age in a basket for a few days before I would open it in the sunshine, because, that's basically what I had. So because I was really obsessed with making sure I wasn't exposing myself. In the beginning, we didn't know what we were exposing ourselves to or how to keep ourselves safe. So we really all, I think, became a little bit obsessive at that time. Or disconnection and withdrawal is another. The third one there is around negative alterations in cognition and mood. That's where people really become very persistently negative or have negative thoughts or trauma-related emotions. So things like fear, or horror or anger or guilt might be present. Shame is another big one that we will see with people, or have very constricted emotions. So inability to really express positive emotions, even in the face of something that would ordinarily make them happy or feel positive. And we might also see alienation and withdrawal from others. And then the last one is kind of arousal or hyperarousal, we might call it. So people startle very easily, agitated, sometimes combative is a part of that, maybe be impulsive in their behavior. And also we might see something like recklessness or self-destructive behavior. So it may look different in all people, but in general, we might see those behaviors that our trauma responses fall into those 4 main categories. I'm just taking a peek in chat again, making sure you all are okay. Yeah. And I know Debbie's answering your questions. I'm just checking to see if there's anything I need to answer for you as we move through. So that's kind of the what happens and where it comes from kind of thing. Thinking about trauma responses, I actually have really come to detest the way we use triggered in our lexicon as well. I think we all use the term triggered a lot. If it's something you use, apologies. I don't mean it in any way that's judgmental, but I absolutely think we use the term triggered a lot, and it gets pretty casual in the way we approach it. I mean, we throw it away when something bothers us, or touches a chord in us in some way. But really, from a trauma response standpoint, what triggered means is that it's the experience of having an emotional reaction to something that's disturbed us. So it might be something like violence or the mention of suicide or those kinds of things. And we certainly get triggered by our media right now all the time. I don't know about you all, but I have to absolutely limit how much news I watch. I'm creeping back into the area of that's a little too much, because it's overwhelming. And I understand that I'm feeling the way I'm feeling because I've had a little too much intake of news. So, but social settings are the same. We might have conversations that trigger us because there's details in there that are overwhelming. People are asking about sharing the PowerPoint post-training. Yes, you will have that. That will be posted for you. Dr. Van Horn is not with us at the moment. I don't think she is coming to the training today, though, and she does post it post-training. So you will have access to those slides. So anyway, the term triggered is really about the experience of having that emotional reaction. And there's a big difference between being triggered and being uncomfortable. And feeling trigger isn't just about something rubbing you the wrong way. Because when someone has a history of trauma, being around anything that reminds them of the traumatic experience can really make them feel like they're experiencing the trauma all over again. So it causes this flood of chemicals. It's like a chain reaction that happens in our body and in our brain specifically, so that the person may not be able to recognize or distinguish between what's happened currently with them and what they experienced previously. So it's like it's happening right now because all the right chemicals are present, all the right areas. If you were looking at their brain under a PET scan, all the right areas of their brain are lit up that should be lit up if they were experiencing that. Some people cope with stressful events more easily than others. And if you think about the impact that those events might have on someone, for example, who has a mental illness or who has a cognitive disability, how that might be different in people who experience differences in the way their brains function. All right, just taking a peek that everybody's okay. So a trigger response, what happens is there's a trauma trigger. So something happens that reminds the person or puts the person, starts that chain reaction of the flood of chemicals. And it reminds the person of whatever has happened in the past, and the person does one of the following responses. They either fight, and I will tell you, my primary response to being startled, if someone startles me, I'll have to tell you a story about my husband in a minute. I absolutely fight first. Some people run away. I always have said I'm just too short and too slow. And I think the reason that I fight is I realize I don't have a chance if I'm trying to run for something. Running away is flight, right? So getting away, fleeing the scene. You might also see attachment issues, or you may see someone freeze. So attachment issues is sometimes called fawn. And it's like maybe placating would be another word that we might use for that, or freeze. So just absolutely be overwhelmed. And I actually worked for a very long time in rape crisis. And one of the things that a very wise doctor that I worked with told me is that really, particularly in women who always seem to have a lot of guilt about some of the things that happened when they had been attacked, because they would freeze and not fight back. And people would always say, why didn't you fight back? And the doctor said, what happens is the blood rushes from our extremities to protect the womb. So in women in particular, freeze is one of those things that is kind of biologically what our bodies do to protect us in case we're carrying a child. So physically, our bodies know what to do when they're faced with any of these situations, and we all have different responses. So to tell you, I was one day I was living in a loft downtown here in Greensboro, where I live, before I lived in my house. And I was vacuuming, and this loft had like sort of as you walk in, it had an upper level, and then you walk down into my living room. I was vacuuming, and I was dating my husband at the time, who had a key to my apartment, and it was time for him to come over, but I wasn't paying attention to what time it was. Vacuum's very loud. I couldn't hear what was going on, and I was looking down at what I was doing. And when I looked up, he was standing there. He had let himself into the apartment, and I picked up the vacuum and I swung it at him, because I fight when startled. And you probably all know those things about yourself. That's a little bit of a humorous thing, but for most people, that is so spontaneous. Like, we can't, it's a funny story now, but at the moment I could have hurt him. Thank goodness I didn't make contact with him. Maybe I'm not a very good fighter. But for all of us, we have that instant response to whatever that trigger is. And I might have different responses to different triggers. And that would be true for anybody who has a trauma response. So the term triggered is really about having an emotional reaction. It's instantaneous, and it's caused by a chemical reaction that starts in our brain and kind of floods through all of our synapses just kind of instantly. Sorry, I'm having trouble advancing my slides here. Earlier, my computer was going to sleep. My internet was blinking out, so I'm not sure what's going on in the world of the cyber gods today. Gabor Mate, most recently famous, although he's been famous for a while, but I don't know if he has just interviewed Prince Harry or is going to interview Prince Harry. If you follow any of the royal stuff, which I occasionally guiltily do, but about trauma and his responses. But he is a famous Hungarian Canadian physician, author, and he has a background in family practice, so medicine, and a very special interest in childhood development, trauma, and like lifelong impacts on physical and mental health. And he also talks about how it's related to how trauma and the impacts of trauma may be related to autoimmune diseases, cancer, attention deficit disorder, and addictions, and a wide range of other co-occurring conditions. And his approach to addiction really focuses on trauma that the patients that he sees in his medical practice have suffered. And what he's looking to do is address this in their recovery. So he has a book called The Realm of Hungry Ghosts. He talks about, and it's about encounters with addiction. He talks about the types of traumas that people experience, and how that may induce substance use disorders, and how that affects decision-making in later life. It's one of my favorite things to kind of point people to as we try to understand the impact of trauma on people and on decision making, because he does a really nice job of explaining extremely complex things that happen in the brain in a way that's very easy to digest. So if you have the opportunity to read some of that, it may help you just kind of understanding what's happening in the brain and the body, but in a way that to me is much more friendly than if I just went and read about, all the science that's out there about trauma and what happens with dopamine and serotonin and all that kind of stuff. So what it's helpful for us to think about when we're planning with people. And the reason that this is a topic that's person-centered in nature is that almost everyone, I believe this, and I know a lot of other researchers, a lot of other people in our field believe this, almost everyone who has interacted with a system has experienced trauma. That's easier for us to believe now because we ourselves have experienced trauma in the last few years. I think a shared trauma, although Bessel van der Kolk, who is our leading expert on trauma in the US, would say, no, that really wasn't a shared trauma. I don't agree, and I think a lot of other people don't agree as well. That was very traumatic, what we've just come through. But when people interact with a system, so our system of serving and supporting people, we should assume that trauma is present. We don't need to seek to uncover it. That is not our role, unless, of course, you are a trauma therapist or a trauma trained specialist. If you have that role, then okay. But for the rest of us, we need to just assume that it may be driving some of what we see, but we don't need to dig into it. It may impact the way people behave. It often does. And it may impact how they make decisions. In fact, it almost always does. So our role then, particularly when we're thinking about person-centered plans, is to not develop a plan unless we are committed to acting on the learning. That's true whether we're talking about trauma or not, but it's especially important for us to remember that here. So those of us who develop plans for people who use supports and services need to understand trauma, and we need to understand that it may be present. We need to act on the learning, meaning that there needs to be support developed for each person that is consistent with the trauma that they've experienced, the supports that they need to be resilient. And that's what we would be building on in their plans. And the people who implement the plans, so those of us who carry plans out, need to have a basic impact of what trauma is, what triggers people, and what is good support. We do not need to know the details of the trauma. I even say this in my clinical practice. So I work with people who have mental health concerns that are related to trauma, but my first conversation always, particularly if I know trauma is a part of their story, because frequently I will know that through a referral, is I do not need to know the details. For some people, they feel that sharing those details actually gives them a sense of relief. And that means that I need to engage with them around that, and I may have to hear the details of that trauma. And that means I have to take care of myself in those situations. So we'll talk, as I said, about vicarious trauma, but I can work with the symptoms of trauma without knowing the details. And I think too often the details are salacious, and so we find ourselves kind of leaning into that part of the story because it's interesting, but it's not necessarily healthy to encourage that, because we don't need to know that to be able to make an impact and to help people be resilient. So I would say that first, assume that trauma is present. And I'm talking about typically, not always, but typically it's that slow drip kind of trauma, the little T stuff. Can you imagine using services and supports for 20 years of your life and feeling like no one ever really heard how you wanted to live your life? So you just haven't felt heard all that time. Or you still don't live in the place that you want to live in, and no one seems to be willing to help you figure out how to do that. Or you've never been able to work because you haven't tried things out. So many, many things could be a slow drip trauma. So assume trauma and don't dig into the details of it would be my first two tips, unless it's your role to dig into the details of it. Also, it's important for us to remember that families experience trauma as they interact with our systems. So often, families may be experiencing trauma in the form of shame from the professionals that they've worked with. I will tell you, in the last couple of months, I have brought my nephew to live with me. He's 15. His mom passed away in January, my beloved little sister. And so, we're adapting. I've never had children. I'm a 53-year-old first-time mom of a 15-year-old boy. He's a delight. He's a lovely child, and I'm so glad we have him here. And also, it's been a huge shock for our family. And as we've talked with professionals in school systems and et cetera, doctors, all the people that you talk with, and just kind of setting up a life for someone in a new place, I totally get what people mean by shame. So there's all kinds of questions that are asked of me that I can't answer because I didn't birth this child, and I've only had him in my life for a couple of months. Well, I've had him in my life since he was born, but had him in my home for a couple of months. And there's a lot of stuff that professionals say that I think, wow, if they really knew how that sounded, like, have you thought about doing it this way? Because maybe if you did this, then this would happen. And I'm like, whoa, that experience has really been eye-opening for me. Although I've been training this particular slide and saying these particular words for much longer than I've had this child in my life. So trauma is something that everyone, even if they don't recognize it, actually may have experienced. And family trauma can really impact your entire family unit. So we often discuss it in conjunction with generational trauma or trauma that gets passed down through our generations. But I would say systems are really good at inflicting trauma on families. So I won't ask you to share this in the chat, but I just want you to think about this. How many of you have a child with an IEP who you feel traumatized after you have been a part of a IEP meeting because you feel like I spent all this time, I see a couple of hands going up actually, you spent all this time thinking about what would be best for your child, how you want your child to experience, what they need, and you go in and it's not anything like what you dreamed for them. No one heard that. You didn't get it anyway. So that's a pretty typical example for almost all of us who know someone whose child has an IEP. They'll tell you these stories, right, of IEP meetings. So it just gave me an extra little motivation as a professional myself to watch very carefully how I engage with people so that I am not adding trauma to already pretty heavy load that families are carrying. I'm also going to talk about professionals as well in just a moment. How this all comes into play, though, with our planning, our person-centered planning, is that often we find ourselves putting supports in place for people to deal with or to manage behaviors that we might see. I'm checking in chat because when I see something flash, I just want to make sure. Yes, the slides will be available to you all after the training. They will be posted for you. So often we find ourselves in planning with people, putting supports in place to address a behavior. So it's helpful for us to understand that trauma responses are different than intentionally produced behavioral responses. And this will be hard for some of us, I think, sometimes because behavior, even the word behavior sort of implies volition, like there's intent behind this, which is not always the case. Often people are doing things kind of from an unconscious place. I know we certainly are. We're all sitting here behaving right now, whether we know it or not. When a trauma response is present, what you might see is that a person has an emotional response that seems somewhat irrational given whatever the thing is that they've been exposed to. So we might not have even noticed it, but from the person's perspective, something has triggered them. And so the behavior, what they're doing, their action, looks out of context with what's just happened. So then maybe that overreaction is to something that to us looks very small. It's emotionally based often. So we might see fear or shame or anger or all those things I mentioned earlier when I talked about the 4 categories of PTSD. It often doesn't serve the person well, so they don't look good in this moment. And it doesn't help the person move forward. So it doesn't help them move toward what they want for themselves. When the response is one that's classically behavioral, that's when we can think about it maybe having volition. So it has a purpose, it has an intent, it's in place for a reason in that person's life. The person deliberately is doing it, really acting on the environment to get that response. And I think it's really important for us to remember that intent is really important in identifying what the response is. So we need to be asking ourselves, is this volition? Is this something the person is willingly doing? or are they responding to what they're experiencing? And I think more often than not, it's responding rather than doing out of a place of volition. So when a person is having a response that's more behavioral in nature or displaying a response that's more behavioral in nature, there's a goal, and it's to get something they want so that they can move toward whatever it is they want. And you can typically identify what the antecedent is, or what came before that, right? This is important, I think, because trauma response doesn't help people achieve a goal. It happens. And the function can be to often avoid something or escape or to soothe, but it's not effective to help them get toward that thing that they want. And with a trauma response, we don't often see the trigger. It could be very, very unclear to us what just happened. I think it's important for us to think about this when we look at the environments that people are in. And I don't mean placement, I just mean the situation, like their internal experience of the situation that they're in would be one way to think about that. So environment could be relationships, it could be good relationships that are supportive. People tell us how they're feeling with the things they do. So when we see something that doesn't add up for us, a behavior, that's when we have to kind of take a step back and ask ourselves, what do we know about what we're seeing right now? Is this a trauma response? Is this something that the person is doing that is very goal oriented to get something? And it helps move them toward that. It's that time of year when everything is blooming and there's just not enough water in the world to keep my throat from feeling like a sandlot. When we're planning with people, however, there are some really helpful questions that we can add to make our person-centered discovery trauma-informed. The good news is you don't have to learn new person-centered skills. You can use the same person-centered skills that you've been using in every other person-centered conversation and every other person-centered planning meeting, but add a couple of concepts in terms of questions that you ask to make those conversations more trauma informed. And you can do this with every skill. You can do it with the relationship map, with typical day, with learning what's important to people, all of that, it all fits. And the three questions that are helpful, because these are the resilience, these are the kind of pillars to resiliency. So perceived safety, connection, and empowerment. We can ask in those planning conversations and listen for the answer to, what does safety mean to the person, or what are the elements of safety from this person's perspective? So for some people, that's going to be, I have a job I love and enough money to pay for the things that I want in life, roof over my head, food in my belly, that kind of stuff. For someone else, it might be the actual physical things like locks on the doors, or the neighborhood they live in, or access to public transportation. So it could really be anything that the person defines as safety, the elements of safety from their perspective. How and where does the person need power and control? And it's power and control we can support. So it doesn't mean all powerful, right? Or all control. It's the power and control that fits in the context of why we're in the world, to serve and support them. How can we help them be in the center of all the decisions about their life and have power and control? And what connections contribute to helping the person heal or be resilient? So that's about relationships. Very naturally thinking about the relationship map in this situation. So that's a great way to explore about the people who help the person feel safe. Just taking a look here in chat, making sure everybody's okay. All right, thank you. So these are the same questions that are helpful with any person. It's not just for people who are using supports and services. Policymakers, administrators, our colleagues, all of us can benefit from reflecting on these questions, particularly at this time. So many of you, not to start any kind of debate of any sort, but many of you at the end of a time where we were all working from our homes, started having to come back into the office in at first dribs and drabs, and now a lot of people are just fully back. All kinds of situations for how we work now. Sometimes some of us are in the office, some of us are at home, some. And that is a great place to employ these questions around trauma and what safety means to people. all of a sudden in January of 2023, so at the same time, my sister passed, I brought my nephew to live with me, and all of a sudden, without agreement or any conversations, we're all just doing training in person again. I guess we're not, we're here on Zoom together. But all over the US, agencies have just started calling us back to do work with them in person. And I was like, wait a minute, we didn't have a conversation about this. I'm not sure I'm ready. So I find myself on airplanes, and more often than not, I have my mask on, but no one else does. Occasionally I haven't. And I have a couple of colleagues right now who actively have COVID, and it's not as bad as the experiences as people who had it a couple of years ago. But I was like, but did we agree? I didn't agree. I don't know that I feel safe. And that is exactly the conversation that we didn't have. And I thought, wow, is that ever important to remember as we think about our colleagues and what we're experiencing, kind of coming back into the work world again, that we also have experienced trauma, and we might not know the answers for this for our organization, for the people we work with our department. So those are good conversations to have as well. And it will tell us a lot about how we can support people to be resilient. The fact of the matter for me is I have to be back on planes and back in people's training rooms. That's like what we're doing now. I just didn't agree to it, but that's okay. That's what we're doing. So, and luckily so far, so good. I'm knocking on wood right now as we speak. All right, so let's keep going again. And I put Dr. Karen Harvey's name down here. I don't know, this might be in one of her books, I'm not sure, but this is really in thinking through with her what person-centered plans should include. Those are 3 questions that we came up with. We also talked about, and we're going to talk about accounting for trauma in plans, as I said, and I'm going to kind of tie this back into our system response and what our systems need to be prepared for in terms of talking with people. And then pretty soon now, I'm going to put you into a breakout room because you may be tired of hearing me talk at this point. But when and by the way, this elephant that you see here, so SDA last year or the year before, we wrote a white paper about the 9 elements of a person-centered system. And one of those elements is systems that are trauma informed. And for each of those 9 elements, we have an elephant. So because I kept getting tongue-tied and calling them the 9 elephants, because I do such things. So then we very cheekily made some elephants to represent each of the elements. This elephant is our trauma elephant, and you see that he is held aloft just above the troubled water by a balloon that has a heart on it and kind of the world and a heart or whatever to represent the support to keep him out of trouble there. So we talk about this in terms of systems and what they need to be prepared for as well. So I'm going to add a little bit of that into our conversation. But trauma is, if you will, the elephant in the room. In our case, this elephant being held aloft and really assisted to make his way over troubled waters. When we talked about trauma, kind of from the very first slide or 2, I talked about some of the things that people might have experienced, little t traumas, big T traumas. So things like losing control, or loss of connections that are important to us, or missed routines. And many of us experience that and are still to some extent experiencing that ourselves. And I think often if we can kind of start with our own experiences and think about how has it impacted us? How has it impacted my behavior in my daily life? And how might it impact the people who use our services and supports? It becomes a lot easier to kind of wrap our heads around it. But in our systems, everyone needs to have the training that gives a basic understanding of what causes trauma and what the impact of trauma is on the brain and on our behavior. And that can really help us build a foundation for a compassionate system response, where there's recognition that you as employees, if you're an employee of an organization, or the people who are using your services and supports, are all impacted by trauma. And we need ways to refer people for the treatment and the support they need. So it has to be arranged. It's definitely warranted in cases, and we don't always have the resources, or we don't find the resources that we need. Someone's microphone has just come on. If you will turn it off. There we go. I know all kinds of stuff is going on. That's just me saying we can hear you. No one needs to, as I said earlier, seek to uncover anyone's trauma unless you have the necessary clinical training. So if you are a trained trauma therapist, go for it. But for the rest of us, We need to be aware that we are going to encounter it in our work. It's going to be what we notice in the behavior that we see. And we need to know that trauma is the foundation for that, and that people need support, but we don't need to know the details. But understanding and awareness in trauma and its multitude of impacts is critical for every person in our system. If we're talking about staff who provide the work, provide the services and supports, or do the planning with people, they need to be trained as well, to assume that trauma is a potential cause for any challenging behavior that they see. That should always be our first thought, not like, here's this person doing this thing again. And the capacity for skilled and effective treatment really needs to be present, or it needs to be developed in our systems. I'm actually going to put you into a conversation toward the end of our training together and talk a little bit about where we can develop capacity, where you're seeing some gaps. And that really is just to sort of plant some seeds about where your next focus might be for trauma. But if you consider how an assessment of a setting that a person is in, not talking about placement, I'm talking about where that your own home could be a toxic environment, right? You could have trauma in your own home, but an understanding of how to develop healing environments for every person that we support as well, or every employee who works with us. But in systems, the people who create policy need this understanding as well, because it relates to those working in the system and those receiving supports and services from the system. And if we're going to incorporate this into our plans, we need ways to learn, how does each person define a safe setting for themselves? Where do they need control that we can support? And what relationships are healing for them? So there should be an expectation that all of the learning that happens from answering those person-centered discovery questions is going to be acted on as well. So let's talk a little bit more deeply about the plans and the lens that we can look through. There are two responses to loss of control, which is often kind of what underlies that feeling of being triggered, so having a trauma response. The first one is to control everything, and this tends to be kind of how I respond personally. When we feel truly helpless, one response is to think to ourselves, nope, not going to let that happen to me again. So we attempt to control everything, our emotions, the environment, the other people, our safety and health, the safety and health of our family and friends. But the problem with that is there are things that are outside of our control. In fact, most everything is outside of our control. So it's not possible for us to prevent any and all negative experiences. And trying to do that is exhausting. It's an all-consuming, full-time, just exercise, and it's pretty futile, actually. The other response that people have to loss of control is passively giving up. So the other end of that spectrum is some people come to the conclusion that, like, I can't have any ability to exert influence on this environment. I can't do anything about it. Doesn't matter what I do. And I can't control anything that happens to me, or I can't manage this intense feeling that I'm having. Maybe it's grief I'm thinking about, or other emotions or situations. And people engage in a psychological phenomenon called learned helplessness. So it occurs when the person kind of passively gives up, because they've learned from their experience that bad things happen regardless of what they do. So their actions have no impact. And someone who's developed learned helplessness may stop trying to escape the pain, to stop looking for solutions, maybe give up efforts to cope with something or improve their overall situation. And neither one of those is good. Neither one of those responses is good. Control everything, passively give up. Those are opposite ends of the spectrum, but neither of them really works. So sometimes we think we're in control and something unexpected comes along and that control is lost, and we're constantly trying to rebalance. And remember, in our person-centered practices, what we talk about is the balance between what's important to and what's important for someone. And it's really the balance from their perspective. So the important to stuff is the stuff that sits on their heart. It keeps them happy, comforted, satisfied, fulfilled, uniquely who they are. The important for stuff is the stuff that keeps them healthy and safe and valued in their community, the community that they choose to be in. And we're constantly, all of us, negotiating the balance between important to and important for. So trauma is one of those things that causes us to have to rebalance kind of all the time. It knocks us out of balance, or the triggers for the things that are trauma. Also, it's important to think a little bit about why and how we accommodate trauma in person-centered plans. So we're going to think about the people who have experienced trauma needing more than treatment. They need settings that represent the most healing environment, and we can describe those settings through planning that we do with people. So if we can describe the balance between important to and important for, and we've asked those questions about the 3 pillars of resilience to trauma inside of our person-centered discovery, then we have all the elements we need to describe what that healing environment actually looks like. So the order that we do this actually matters. And I think this is true for all person-centered plans. It is not just about when we're talking about trauma. Always learn what's important to a person first. So if we start there, then talk about what's important for them, it causes us to walk down a different path in terms of developing supports. So we're thinking about what sits on their heart first, and it means that anything we develop in terms of services and supports that address the things that are important for them are actually done from the perspective of the person in a way that makes sense. So it's like looking through a lens of important to of those things that are important for them. And that helps us describe that balance and how to best support them. If you are a person who is doing planning, here's some practical considerations for you. This would apply whether you're developing a formal person-centered plan or you're somehow contributing to a person having a good life, or if you're using this even with the people in your organization. So thinking about your colleagues and yourself and your experiences at work. Having a basic understanding of trauma and access to people who have the answers to questions and can give advice about trauma, so knowledgeable and trained professionals, is important. And particularly when we're formally planning with people, that is something that we need to take into consideration. And for all of us, adding trauma-informed questions to the discovery process, it's not just effective, it's necessary. We should be asking those questions all the time. Now, it says done by trained facilitators. So you don't have to be trained deeply in trauma to add those 3 questions. They're perfectly natural questions to ask inside the context of person-centered discovery. So when you're having a conversation, maybe using the relationship map, learning about who's in a person's life, a natural question to ask there is about the people who help you feel safe. So, if you were feeling frightened about something, if you were feeling worried about something, if it's been a bad day, and those are questions that kind of substitute or proxy for who helps you feel safe. So it's a great way to open that conversation up. Use your person-centered skills that you already have and include those trauma-informed questions in a way that's completely unobtrusive, and it fits for really describing the balance between important to and important for. And I already talked a little bit about the 2 responses to loss of control. So control everything, control nothing, passively give up. I think it's also important to understand about how important the environment that the person is, how important the environment the person is in is. That was hard to say. And I'm not talking about placement. I'm really talking about the person's internal experience of the situation that they find themselves in. So your own home, the first one here is toxic. Your own home can be toxic if you don't like the things going on there. So when an environment is toxic, it's extremely upsetting to a person. It may cause them to be aggressive or depressed, withdrawn. And it results in a feeling of someone having power over you. So telling you what's best for you. And often when we see the behavior that is aggression or depression, we try to control that. We look at that behavior and we say, that's the problem. That's what we need to do something about. When really we should be looking at the situation that the person is in not placement, but the situation of the person's life, and asking, what do we understand about this person that's helping us know about what causes them to respond with aggression or to be depressed? Is there something that is triggering in them a trauma response? And so is that the behavior that we're seeing right now? So a toxic environment. Another environment, also not good, tolerated. In some ways, this is a lot sadder to me because we see just no growth. We see no movement whatsoever. We might see people who have that learned helplessness situation where they've just passively given up. And they might have been in a toxic situation, but they may feel powerless to do anything about it. So they're just going along to get along. And the sad part about that is that there's no growth. There's very little movement. Just taking a peek here. Okay, you all are still waiting on slides, and you will be getting them. So toxic and tolerated environments versus environments that are supportive. Sorry, my slide stopped moving again. Which work for most people in supportive environments. If people are using services and supports, a supportive environment is one where we're focusing more on relationships than we are on the tasks that have to be done. There is a type of shared power that's very side by side. We see people really blossom in those situations, particularly if they've been in a toxic or tolerated setting. And we see people start to really grow. And the last environment is really the healing environment, where particularly people who have been in a situation that was toxic or tolerated, have been injured by that situation, wounded in some way, that we're focusing on not just the person-centered practices, but good clinical practices to marry to those, partner with clinical supports, because that helps the person heal and be resilient, to have that post-traumatic growth that I was mentioning earlier. And many people actually come out the other side of trauma with some remarkable skills, with some remarkable coping skills, with some remarkable insight about who they are and what they need for their life, know themselves much better. And we hear story after story of post-traumatic growth. You may have your own story of post-traumatic growth. The difference between these environments is that when it's toxic or tolerated, the feeling is of power over. Someone's telling me what's best for me. They're setting up the conditions of my life, and I'm being forced to live inside of them. When it's a supportive environment or a healing environment, the feeling is more, I share power with you. We make decisions together based on some kind of shared understanding of how I want to live my life, right? It's not about what the system thinks is best for me. So there's power with people versus power over. And I know if you've been in our person-centered trainings, we use this slide all the time. It's so important that we understand how an environment actually impacts what a person does. So when we see those behaviors, control everything or learned helplessness, that's a really good chance for us to slow down and ask ourselves, what is the person experiencing where they are right now in their situation in life right now? What is their behavior telling me about their situation? Is there trauma that's underlying that? So I would like to send you into a breakout room for, let's see how much time I can give you. I was going to give you a little longer, but let's say 20 minutes. And I want you to think about person-centered skills and how those can be used to learn things in the person-centered planning process. And remember the 3 questions that we want to add to do good person-centered discovery are around how a person defines a safe setting. So what is a safe setting from their perspective? Where do they need power and control that we can support as a system? And what relationships are healing? So I want you to talk about those specific person-centered skills. And if you can't remember the name of the skill, it's okay. You can just say, for example, we call the good day, bad day skill or the typical day skill. Learning about a person's day might be how you describe it. It's fine. Just describe it with one another. But I'd like you to talk for about 20 minutes because I want you to really think about realistically, how can you use the skills you have to bring these conversations and these trauma-informed questions into your person-centered planning process. So Debbie is going to open the breakout rooms. We're going to give you 20 minutes. When you come back, I'm going to ask for a report out from you all. So just be willing to summarize with one another a little bit to share back in the main room. All right. Welcome back, everyone. I think you've all returned now. I hope that was a good conversation, and I am curious to hear about it. I was going to say, did you miss me? But I'm afraid people would say no. So I'll just ask you, tell me about your conversation, please, in your breakout room. What do you think you can do in terms of using some person-centered skills to learn things in the planning process that would help you be more trauma informed? And I see there were a couple of little technical issues going on, so sorry about that. Let us know if we can help when you're having those, and we may be able to adjust things for you. Anybody want to share what you talked about in your breakout room? By the way, I do not care if you call it by the correct name. If you can just describe how you would approach this in a person-centered way, getting some of these questions into the person-centered planning process.
Hi, this is Marsha. I'm a service coordinator.
Hi, Marsha.
How are you? So in our team, our breakout group, we talked about the fact that, and I'll have Shane join me if I miss something, but we talked the fact that we would use, well, I suggested that maybe in an intake process, when people are first coming in to DDA, that the eligibility department would kind of look at this as a tool to reference people coming in for services. Maybe they're having some trauma informed things going on. And then we said with the big T and little t that we could use this around our ISP meetings or case conferences where we have these emergencies and things are going on with people that they're not necessarily a behavior. It could be a big T or a little t that's happening, and kind of looking at the signs and for trauma and what it looks like. That's what we talked about in our group. And then Shane gave a good example of what he can speak on it, and informed care with a person he supports on his caseload.
Thank you, Marsha. Shane, are you out there?
I am. I think Marsha did a good job at explaining what we talked about, but yeah, we were just trying to be more specific about sometimes people communicate that things aren't okay, and we may recognize that maybe it is part of trauma, and that doesn't mean they're going to say, oh, it's because of my trauma.
Right.
We may just see the signs for ourselves, and it may not be that they can necessarily tell us all about it or want to, but maybe even a trusted person that kind of knows about the trauma could be the one to kind of speak up. But a lot of it is like, for example, I have a person who came from foster care, you know, a home family, even though it wasn't her family, but it became her family environment. And then when she became an adult, came into services with DDS, where we have supported living, which looks a lot different. It's a step towards independence, but it's not all the way there. And it was a very big, difficult transition for this person. And a lot of it was the key words that she would say, like, it's like living in a dorm. It's like, you know, all these people around. I don't know these, I don't want them in my business. And, you know, one part of the team is like, oh, it's a lot of behavioral issues. And the other part of the team is like, looks like trauma to me. Like, but we don't necessarily, she doesn't want to address it, but let's look at how we can change, how we can adapt, especially things like, how does each person define a safe setting? What do they need, you know, to feel like they have control of their setting? And how can we look at the supports that we typically see or we're providing, and how can we shift and adapt them to make it more informed that we know that they have some trauma? And so what can we do to make them feel safe and feel in control?
Excellent. Shane, that's really brilliant, very wise what you said about they may not know that they have trauma. Frequently when I work with people who around things like maybe a lifetime of not having friends, and the many people I see in therapy as adults had the experience of being a person who did not have friends over the course of their life, never had any friends, and that's how they describe it. And I know that that's a traumatic experience, but they don't say that I experienced the trauma of not having relationships that mattered to me. So in that story that you shared, you've identified someone had a situation where they may have felt safe. They had people around them that helped them feel safe. And then they moved into a new situation and there's new people to deal with. And that's one of those questions, right? So what are the relationships that would help them be healing or resilient? So thank you so much for sharing that. People may not say, I had trauma and here's how it has impacted me. Sometimes we don't know. Often that's unconscious. Thelma's hand is up. Thelma, is there something you'd like to add?
Yes, I just wanted to discuss what our team came up with.
Go for it. Thank you.
Yeah. So we talked about what is a safe setting for the person, and we talked about trust and comfort. Because if somebody has trust, they will be able to open up to whoever the staff or whoever they are dealing with, and if it's on their comfort level, they are comfortable with their setting. And we also discussed that most of our discussions are kind of individualized because what goes good for me might not go good for any other person. So we always have to look at things from an individual standpoint. So we talked about control, and in the same control, we feel like feeling safe within their own circle. Like when we have some of the team members talked about having an ISP meeting, and people would just get up and go use the bathroom without looking at the person and saying, hey, can I use the bathroom? Can I use your bathroom? Because it's their home. And them not having maybe like keys to their home can create a discomfort that maybe we wouldn't know, but it might create a safety issue for them. Uh, so, these little privacies also should always be in consideration when we're doing anything with the person and for the person. And we talked about like and admire, the things that will create a safe healing for them or a safe space for them, things that they really like. And I just kind of mentioned to the team that I have a person that relationship with her husband or her boyfriend is always very important and key to them. So if we're doing anything, we have to think about that as one of the persons we need to make sure that is included. So those are the things we discussed.
Thank you, Thelma. You pointed out so many things that are helpful when we discuss environments in particular, like trust and how important it is to have that foundation of trust, how that makes for an environment where we have power with people versus power over people. You pointed out many of the person-centered skills by name. So that was a very thoughtful conversation, and I appreciate all those highlights that you shared. Anyone else out? Oh, of course. Thank you. Anyone else out there who would like to share before we move on? Okay, the other thing you can do is if I start talking before you've had a chance to talk, either interrupt me because I don't mind at all. And you absolutely can share aloud, but if you want to put it in chat, maybe don't feel like speaking aloud, that's also okay. So please don't hesitate to do that. Thank you for having a conversation with one another. We'll do another one of those. Oops, I was supposed to put out, see, I made this fancy slide with a microphone so you could report out, but I forgot to put it up. So there we go, we'll keep moving. And we're going to have another conversation right at the end of our training as well. So you'll get to go back and you'll have to let me know. You can let Debbie know in chat. Would you rather stay in the same group? Do you want me to mix it up? So you all decide, put it in chat for us, and we'll arrange your groups that way. The next time we'll just reshuffle if we need to. We also need to talk a little bit about secondary trauma, or you sometimes hear it called vicarious trauma. And I think for those of us in our field, we're exposed to a fair amount of this. Even some of the stories that you just told about supporting someone who's having what looks like a behavioral response to something that they are experiencing or an environment they're in can be a secondary type of trauma for us. But it's when the stress that we experience in working with people who are exposed to trauma begins to interfere with us personally. So our professional life, our personal life. And we see examples of secondary trauma that are found in social workers that are big. I study this a lot because I am a social worker and I do work with people who are in, I work post-trauma with a lot of people. And, you know, obviously I hear sometimes the details of the situations that they've been in. Sometimes I don't hear the details, but I see the impact, and that has an impact on me as well. Social workers who work with people who are abused children is a very common situation for exposure to secondary trauma, but many situations we find ourselves in. Those of you who work with older adults, those of you who work with people with traumatic brain injuries, there is vicarious trauma that comes along with that. And we're going to talk about therapists leaving the field in just a few minutes during the course, particularly of the pandemic, but unfortunately, it has continued at a pace that is pretty alarming. And we're also going to talk just very briefly about direct support professionals who are coping with trauma as a result of providing supports and services during extremely challenging time. And the challenge currently is that there aren't enough of them to go around. And that's true, I think, for therapists as well. Doctors and nurses are also experiencing this. But some of the common signs of secondary traumatic stress are things like emotional feelings like numbness or detachment, or feeling overwhelmed, or maybe even hopeless. And certainly I have talked with a fair few of my colleagues in the mental health profession who are feeling overwhelmed and hopeless right now. Every time we have a mass event of some sort, like a mass shooting, and I said I wouldn't get it too much into the current climate of our country and what's going on, it can really overwhelm the helpers in those situations as well. There can also be physical symptoms. So having low energy, feeling fatigued, the kind of stuff that looks like burnout is often the physical response to exposure to secondary trauma. And we might see behavioral stuff. So changing your routine to avoid something, or maybe engaging in self-destructive coping mechanisms. So I'm thinking of things like maybe drinking too much, or who knows what else, right? So they can have emotional secondary trauma can have emotional side effects, physical side effect, or symptoms, I guess I should say, or behavioral symptoms as well. I'm taking a peek in chat. I see stuff coming up in there. Good. A lot of people are saying same group. You bonded. That's so nice. All right. Trying to make the slides move is just sometimes more than I can do. It overwhelms me. Oops, did I miss one? Yes, I did. So one of the things that many of us have been exposed to in the last few years in particular, and it's something that I'm very interested in because I'm a death doula. I do work with people who are grieving, work with people who are experiencing what I call complex grief, or what the research calls complex grief. But this is really about grief being a complex set of symptoms. It's really been difficult, as I was saying, to find mental health counseling. And this really impacts the work that you do when you're planning with people who use services and supports, because finding the help that people need has been more challenging of late. In the United States for the last few years, and this actually predates the pandemic. This is not really related to the pandemic. There has been, long before the coronavirus, there has been a trend in this direction. But after a couple of years of unrelenting stress on the system, now we're in I don't even know what year we're in. You're at 22, I don't know, third year, fourth year, I don't know where we are. The turmoil that came along with that, the grief that people are experiencing either in their personal life or in their work life, or in working with the people that they support. A lot of people are seeking help, but confronted with a system that is beyond its capacity. It's inadequate right now to address the need that we're seeing. And I think that that's kind of been plainly exposed. If you've tried to seek help yourself, or if you've tried to seek help on someone's behalf, it is harder to find assistance than it has been in the past. A lot of therapists are not explicitly trained in providing support for people who are grieving. I think is part of what we are experiencing. It's a part, it's not all of. And traditional models of grief are really not adequate for the complex needs that a lot of therapists that I know, and certainly myself, are seeing. Things are much more difficult in terms of what people are experiencing than they have been in the past. The federal government's mental health and substance abuse referral line in 2020 fielded 833,598 calls. So that was 27% more than it was in 2019. And that's, of course, before the pandemic began. And in 2021, the number rose to 1.2 million. So when the American Psychological Association surveyed its members, and this was last fall, they found that there was this huge surge in demand of new referrals, particularly around anxiety and depression and trauma-related disorders. So right now, that's what's prevalent kind of in our world. But 65% of the therapists that they surveyed, so it was more than like 1,100 therapists, psychologists, social workers, et cetera, who responded, said they had no capacity for new patients. And 68% of them said their wait lists were longer than they had been prior to the pandemic, so in 2020. And I will tell you myself, I practice, as I said, psychotherapy. I do that online. I have a private practice. And I cycle off my availability for about 3 months at a time, because if I turn on my availability saying I will take new people, within about 4 days, I get at a minimum 60 referrals. And I can't take that many. I can't see that many people. I see people before and after work. So at a maximum, I can carry a caseload. I hate that word, but a caseload of about 25 people. And I can't see all those 25 people every week. So, and most therapists are having a very similar kind of experience. Like, it's just overwhelming, the number of people who are needing help. So back in December, the U.S. Surgeon General issued an advisory on the urgent need to, actually, this was December a year ago, so it's a little more than a year now, the urgent need to address the mental health crisis in the U.S. And there was also a Senate committee hearing right after that in the early spring of last year to address the growing mental health and substance abuse problem. Because what we know, and I said this a little bit earlier in our presentation, is that when we have mental health problems show up in our system or show up in us personally, it lags whatever the stressor was. So mental health experts are actually predicting that the current situation we're in is actually going to continue to rise, that there are going to be more therapists leaving the field and more people in need of assistance for trauma, for grief, for depression, and for anxiety. And the toxic psychological stressors that many of us have experienced in the last few years have created some risks that are physical in nature. They've created daily disruptions to our schedule. Our lives have changed significantly from it. Certainly, uncertainty has become a part of what we can be sure of. We're living kind of in a world of uncertainty. Social isolation was something that many of us were grappling with. And a lot of us have found that our social patterns have changed. So the people that we access for support, whether they were in our work colleague group or in our communities, are different now. We may still have those social networks, but they look a little bit different or function a little bit differently. And a lot of people have experienced financial difficulties as a result of this. So those are all known, well-known causes of mental health issues, and thereby physical health issues as well, because anything that affects the brain impacts the body. The same is also true. Anything that impacts the body impacts the brain. And this is my number one reason to tell people to exercise, because anything that's good for your vascular system is good for your brain. Anything that's good for your brain is good for your mental health. So if you need a reason, that's a really good reason. But adversely and collectively, there are many characteristics that have been identified as having great negative effects right now on the system that we have. That sounds super dire. It is a crisis. And at the same time, we're having a crisis of support professionals in terms of like having access to enough people to provide the supports and services. So that's to say that when we're planning with people, we have to recognize that we may identify that there's a need for additional support for someone, additional professional support for someone, but the access to it is not as great as it has been. So that puts, I think, a lot more focus on us making sure that person-centered plans have supports written into them in a way that can support the person to be resilient, to have access to relationships that are affirming for them and, healing for them, to have the environment be as best it can be representing balance from their perspective. We may not be able to handle the need that a professional would handle, but we can do these things through our person-centered planning process, and it will make a difference in how supported the person feels. Because what we're trying to do is mitigate the impact of this. So if we've lived through this traumatic event together, and that includes therapists who live through it as well, or the professionals who live through it, or those of you who are working with people, we have a better capacity right now, I think, to understand how people are impacted by trauma, and that there are so many more people who need access to care. So the three things I would ask you to consider in terms of just mitigating the impact and how our planning process and what we do can actually make an impact is the first, we need to address loss and grief as it shows up. So as we're having our person-centered planning conversation, we need to listen for those opportunities that help us understand that what the person is doing, so the behaviors that we are seeing and what they're saying may teach us something about how to support them better. And we can refine our supports through what we learn, to learn and understand for ourselves what are the stages of grieving. And I don't think of I know you've heard the DABDA model, which is the 5 stages of grieving. It's not that I disagree with that model. I just feel like it sort of implies that things are linear, and they're not. Grief is complex and messy and circular, and we kind of move all over the place in it. But really understanding what happens to people when they're grieving and what some of their experiences may be, what they may be thinking and doing, is helpful for every person who works with others. I just think it's good for humans. We're not great at talking about grief and loss in our country, to be honest. We also need to build resilience in ourselves and in the people who use our services and supports. And I'm not talking about helping people tolerate bad situations. If people are in bad situations, bad environments, we need to address that directly. They need to be out of those environments. We need to build environments that they need to be in. But we also need to understand that if we incorporate resilience building activities into our day-to-day efforts, so things like healing environments that include access to things that support people to be healthier, whether that's psychologically healthier or physically healthier, that should be a part of what we're paying attention to, and understanding that there is hope. So post-traumatic growth is a real thing. Most people who live through something big actually live through it and grow out of it. So not every person who experiences trauma forevermore has difficulty psychologically or physically as a result of that. Often they take that and integrate it into learning about themselves. And we can be a part of that if we help people have the supports they need. And then finally, really listening to people who are doing the supporting and those who are being supported, and responding to the kind of concerns that they have, making sure that that is part of how our system really addresses trauma. In terms of providing healing environments, I think it's important to remember that where people are in settings where they feel safe and they have a sense of having power and control, those same 3 questions you just talked about, they have relationships around that make them feel supported, or whatever, relationships that matter to them, that helps them be resilient. And there are a number of things we can do to create environments that are more healing. So in your organizations themselves, if you're talking about with your colleagues, you can be more proactive about mitigating the impacts of trauma if you're doing things like having wellness initiatives inside your organization. Maybe you're offering yoga. Maybe you're offering Qigong. Maybe you're offering other things that help reduce stress. So mindfulness practice. I know a lot of organizations right now that I'm working with are doing kind of group walking projects, because walking is a great way to just kind of get moving and release some of the physical trauma that we may carry. So they do it for a number of reasons. They may call that a weight loss strategy, or just a way to team build. There's all kinds of reasons to walk together, but it does have an impact on mitigating the stress of exposure to trauma as well. And anybody, staff and those who use services, offer those other resilience building activities universally to people. So not just people who use services and supports, but to ourselves as well, making sure that we are keeping people, organizations really should consider building these practices into the everyday environment. It's an expectation that we care for ourselves. I know in our own staff meetings at SDA, we're a teeny little team. There are 3 partners and 2 employees, so there's 5 of us total. But our staff meetings have started to include the question, what are you doing for yourself this week? And it's really about what you're doing to address your stress, to keep yourself joyful, to, take care of your body, all of those kinds of things. And it's just an encouragement for one another. We don't, if someone's like, this week I've got nothing good planned for myself and I'm going to eat garbage all week, we don't fuss at them, but it's a really good reminder that we have to take care of ourselves because we are, our greatest resource that we have. And I think in our organizations, often we think so much about caring for other people, but we are not caring for ourselves. So this is really universal. And it's something that as organizations and systems, we can build that right into the way that we serve and support people. And it's important for us to know that we can respond to expressions of loss as we experience them, respond to the expressions of people's exposure to trauma, whether it's the big T trauma or the little t trauma, and build trauma-informed discovery into our planning process. We can't ignore the trauma that we've experienced, and we have to really be intentional about addressing it at the systems level as well as the individual level. So never in our history have we been more primed for understanding what trauma is than we are right now. But how we respond to trauma, whether it's in a planning conversation where some piece comes out that we learn about, or a behavior that we see that we think, like Shane said, that looks like trauma to me, and it's, so as we have those realizations, how we respond to that can actually diminish the impacts of trauma later on. It can help people be more resilient. And there are a number of things that people need in terms of building resilience to trauma. I'll get to that in just a moment. But in addition to that, people will often ask about risk as it relates to trauma. When we're providing person-centered assessments for people, and I'm going to give you a link, not a link, I'm going to give you a reference to this in just a minute. We kind of think of a couple of things. One is we sort of want to bubble wrap people in our system. We say this all the time, but we want to hold people safe. We want to not let them get hurt, but certainly that's true. But the only place that learning and to some extent satisfaction occurs is when we take risk, and we have to take risk with our hearts. We have to take risks with our safety sometimes. And the key is reasonable. How much risk is reasonable? And so there is a person-centered assessment that's particularly helpful for organizations to take a look at, that was developed by Mary Lou Bourne when she was with NASD. She's now doing her own consulting work. And I'm going to show you an example of that here in just a moment, because there's one specific section of it that may help you think about your organization and your system that you work in, and whether or not you are maybe risk averse in a way that is keeping people from being able to answer some of those questions around trauma-informed discovery in a way that helps them take reasonable risk. So it gives us some clear guidance on documentation of risk in person-centered service plans, but it also helps us talk about how to demonstrate how we have talked about risk with the person and with one another, particularly where behavior is concerned. And I'm going to show you a little model for this that has 2 factors. One of them is probability, and the other is impact. So one of the things that kind of comes to mind when I think about risk, right? And you think about our own lives and how we make decisions. I was working with a group of person-centered thinking coaches. I won't tell you what state they were in, but there are folks who are doing person-centered organizational work. And when I asked them about the most adventurous thing they ever did, they said, everything from like riding a roller coaster at the local amusement park to catching a rattlesnake. And someone said, oh, I gave my heart away at 22, which was the most adventurous thing that she'd ever done. So some risk is really in the eye of the beholder. But we really have to consider, and this is important, especially important when trauma is the topic that we're talking about, how much risk is risk that we can support, how much risk is too much risk, if our organization can support that or not. And we don't necessarily know how to hold those discussions. So we either avoid those conversations altogether and we bubble wrap people, or we just say no, like absolutely not, right? Shut that down. So we have to use the concepts of probability and impact. I'll show you that in just a minute. How likely is it to happen? How big is the impact going to be? Who's at risk? Is it the person who's at risk? Other people? Is it us who's at risk? Is the agency at risk? Or our services at risk? And some risk we know, and some risk we absolutely cannot know, right? That we don't know what the outcome of this is going to be. So we have to distinguish between what's known and what's unknown risk as well. So the model or the assessment that Mary Lou has developed is on the NASD's website. It's free to use. You can go and check that out for yourself. Just go to NASD's and type in under the search bar, person-centered assessment. And on section 2.3, that entire section is really about how your organization approaches risk. What is your approach to risk? So with 1 being kind of the least good score you can get and 5 being the most. This is like in terms of how person-centered you are in your approach to risk. I think this is interesting information for anybody who works in our field. This is just one section of it. This person-centered assessment covers a lot of different things like finances, it covers of your organization. It covers all kinds of things, culture of the organization, person-centered planning. We could have actually dropped that slide and it would have been appropriate for this as well. But it really is helpful in thinking about what situation or what's the context that you're doing your work in. And as you talk about trauma and the behavior that comes along with it, and how trauma impacts a person's decision making, this is a really good conversation to have with your colleagues and other people who are helping you plan. So if you are developing something to address that risk, and this is again related to behavior and thinking about trauma that people have experienced, you need some kind of way to identify it, to plan for it, and to actually know what you're going to do in response when you see it. So it's helpful to know what's the behavior that the person engages in. So what is it that the person does? What's the behavior of the activity? What do you see or hear? What is it about the action that we're worried about or fearful about? So already, I know that thoughts are coming to mind for you, for people you're supporting. There are risks that you can identify in the things people do. And I want you to just kind of take a step back and ask yourself, how much of this is related to a trauma that the person may have experienced? You don't need to know what the trauma is, but is this a trauma response? Is this something that has triggered the person? Because if we can identify what are the conditions that are likely to evoke the action, understand what the context is, and what are the likely consequences of the person engaging in the behavior, and what can help them prevent engaging in that behavior, it will tell us what we need to do in response. So what do we do if the person engages in the activity anyway? This is a nice way to think about being concrete as we develop supports that address the behaviors that may come along, or the risk that may come along with some of the behaviors that are indicative of a person who's having a trauma response. So 2 questions for you to discuss. And this is again about probability and oh shoot, I forgot the other word, impact. Sorry about that. It's right on the slide, isn't it? How likely is the risk to occur in this situation? So having a conversation with the planning team and the person, if possible, about what are the circumstances that contribute to it? Has there been frequent or rare history of it in similar settings or circumstances, and other contributors to the likelihood? And then in terms of impact, what might happen to the person? What would the results be long-term and short-term? And what would the results be in terms of, are they life-threatening or devastating for this person? So this may help us determine like how much risk is too much. And I know people want really hard and fast answers about that. It becomes difficult unless you have this conversation and include the person in it. we need a tool, I think, to help people manage this. And right now it's completely up to every planning team to figure out, and it really relies on the personal view of the team members who are part of the conversation. It relies heavily on the degree of risk that your organization tolerates, or the most outspoken team member on your team, and certainly the past history of the agent. And if you're agency, and if you're very risk averse as an agency, and you may be, and I'm not saying that's wrong or right, but you may be, because something has happened in the past, then obviously you're going to have less tolerance for risk. So we have to ask our questions about probability and consequences when we're determining risk planning and the actions that we're going to take. And if we're planning people's day-to-day lives, we should always be thinking first about the worst possible impact, even if it's least likely to occur. And then we have people who are alive and miserable, right? So we have this no tolerance for risk. We're going to first think about how the worst case scenario would pan out. And then we have people who are completely bubble wrapped. So this may be actually a model that helps us think about, how probable is this to occur, and what's the impact that's likely to be? Is it a long-term impact, a short-term impact, et cetera? So I think if you can answer the questions kind of in the quadrants here, it may help you in really thinking about, for this particular person, is this risk a risk that we can tolerate as they make decisions? And I think this becomes so important when we're designing supports, because our natural inclination, I know my natural inclination is to keep people, we're in the world to keep people healthy and safe. So I want to prevent all harm from coming to them. But we have to really be reasonable about that, because we can't prevent all harm, first of all. And we're really also supposed to be balancing that with what's important to the person. So remember, we talked way back about what for the person's perspective actually represents balance between important to and important for. So anyway, if you're interested in that, please go to the NASD's website, and it's the National Association of State Services for Disabilities, I think is the whole, but NASDDS is the website, and type in person-centered assessment and you can get the whole thing. It's free. You can print it out. It's great to kind of think about how your organization is doing with person-centered practices anyway. I recommend it to people all the time. And I'm also going to just kind of bring back that idea of what we can do as a system in terms of responding to trauma. And then in a few minutes, I'm going to ask you to talk again with one another, because I know it can get wearisome listening to me for all this time. So we talked about trauma being a universal experience. Safe for any of us, or for any one of us, can really be defined as free from harm or free from hurt. And so feeling safe means you don't anticipate that you're going to be hurt or harmed emotionally or physically. Thelma, I see your hand up. Do you have a question or a thought?
Yes, you said something about how how we can help people with, I think, with trauma, that have trauma, and how our agency is doing in supporting people in person-centeredness. This is something that I have had arguments here. I really don't think that, I mean, you can write things on paper and it looks very nice, but in practice it's not happening. There's so many practices that is just not person-centered here. Like where you live, you have to go through a list that is, that is already there. You don't have a choice to make your own individualized choice to say, this is where I would like, or this is the provider I would like. So that makes a lot of, creates a lot of problem for the person, because you have somebody living where they really don't feel good and they're battling it all the time, and it creates conflict. And some of the people that I support have serious life trauma that also is impacted by where they live, the providers who don't know how to provide the right services for them, but they are forced to live there. So it's not person-centered. And when I say it, it's like, oh, Thelma, but that's the truth.
Thelma, thank you for that. And I know it's hard to be vulnerable and honest sometimes about the things that aren't going well in our system. So I really do appreciate that. I do think that what that assessment may be able to do is give you a platform for conversation with others, so that you're not always the squeaky wheel who's saying, this isn't person-centered, where you're kind of discussing together, if it is person-centered, how person-centered is it? This is a nice way for us to have kind of a shared understanding of how far we are on this journey. So I would hope that would be something people would be willing to engage in terms of conversation with you. So, and I know, I mean, I've been working in this field a really long time, and I certainly know the system is not designed to be person-centered. It's supposed to be in terms of the law and how we impact people, but it's a system. It's very system-centered. And so most of us are kind of constantly kind of fighting against that in the work that we do. That's me editorializing, by the way. That's not part of the training. But thinking about this concept of feeling safe and being safe. So if safe is defined as being free from harm and hurt, then it means that I don't anticipate that I'm going to be hurt or harmed emotionally or physically. And if you can think about, and I don't want to trigger, and using the word in the very real way, I don't want to trigger anybody in any way, but if you can remember a time when you didn't feel safe, and I want you to really reflect on that moment for just a moment of when you didn't feel safe. Last week I was in Indiana, and Friday prior to me being there, they had, this was in Huntington, they had tornadoes roll through. And so they literally like took houses out on a Friday. So I was there Sunday through Friday of this past week. And so, you know, a full week after that, and they had tornadoes rolling through in the exact same spot. I was very lucky. The place where I was, even though it was all around me, it was like there was a little path that just went around the bed and breakfast that I was staying in, that, you know, there was nothing there. But the storms were terrible. The town was on very high alert. The agency I was working at, I was supposed to work Wednesday, Thursday, Friday. They actually, or Tuesday, Wednesday, Thursday, they actually closed on Wednesday so that they could support people who may be anxious about the storms, or if something bad happened, for God's sake, they would, have to keep people safe, that sort of stuff. So that to me sends me right back to my childhood, my girlhood. I grew up in Louisiana. We had hurricanes, we had tornadoes all the time. And I wonder every time I see the trees making this motion, like, will I be crushed by a tree? That is like absolutely the first thought in my head. It scares me to death. So that is what triggering is all about. It's kind of irrational. I knew I was looking at the weather radar. I could tell that it was around me, but it's not where I was. But immediately I had all that same sweaty feeling, nervousness that, you know, you might experience as if it was actually happening to you. So when we feel unsafe, and most of us can kind of recall a time when we didn't, those emotions that we had, we can very easily kind of pull that up. If you think about what you were experiencing at that time, several emotions often kind of compete for attention during those traumatic events. So when I was feeling unsafe in that situation last week, I was scared and anxious, but I was wearing fluffy, socks because I was in a bed and breakfast because work had been canceled that day. And I was thinking, okay, there's a basement in the bed and breakfast. I could go to the basement, but this place had been a funeral home. And she said, it's kind of creepy down there. So you might not like that. And I thought, okay, well, the one thing I know I can do is I can put on my real shoes. So I'm not running around in my fluffy socks. So that was my preparation for the storms that we experienced. And my heart was pounding for a little bit, particularly when the rain and the wind got really heavy, and my mind was racing. And I was just thinking, what's going to happen next? What am I going to need to do? So I was trying to work because I had tons of stuff to catch up on, and it would have been a great day had I not been terrified. But I had several hours of some anxiety about what I was experiencing because I was not in control of that reaction. That chemical soup was going in my brain. And, I was feeling that anxiety kind of closing in. And, even now, years later, so way back when, those tornadoes, those hurricanes that I experienced set me up so that when I'm in situations like this, I vividly remember those events, right? I know kind of that same feeling as it comes over me. So feeling safe is as important as being safe. And I was safe last week. I had all the elements I needed to be safe from whatever came. Now, obviously, the building, I guess, could have been blown away, but I had a basement. I had, all the things you would expect to need if you were in that situation, but I did not feel safe, right? So if you think about the situations that people find themselves in, I know that's a simple example, but, how can we help people also feel safe, not just be safe? Because we often tell, but, we've planned for this. They have what they need, but they don't feel it, right? And so what most people need, what all people need most, is a sense of safety. And they need to be understood. So what their experience is not something that they can control. That is what's going on in their body. It's a chemical reaction to what they've experienced. Obviously, support, and that's what plans are about. It's about developing those supports. Kindness and empathy in every situation goes a long way. Ways to engage. So that's about relationships. What relationships? Many of you mentioned trust, connections with others. That foundation of trust is so important, and certainly hope. And I think that, as I said, post-traumatic growth is a very real thing. I think for most of us, what trauma does to us is actually makes us stronger, wiser people who have many more coping skills as a result of what we've experienced. But there are times when our system gets a little overwhelmed with what we're experiencing. Do listen for opportunities to learn what helps a person feel safe and connected and empowered, and use those elements whenever possible when you're planning with people to support and assist them. So make sure that those are written into the plan in such a way that others know tangibly what they should do to help support the person. The other thing I would offer to you, just kind of as homework going home from this training, and I have a few more things to share with you, so you're not going anywhere just yet, but there is a video by Brene Brown that you can get on YouTube, and her name is spelled at the bottom of the slide here. It's Brene, Brene Brown. She's very popular. Many of you probably know her stuff, but it's a YouTube video on empathy that is wonderful because it's really about presence with people. So as people are experiencing these confusing symptoms that sometimes maybe, as Shane said, they don't identify this as my response to trauma, or maybe we look at it and we think I don't know what I'm looking at right now. Empathy is very powerful because it allows us to be present with people in their experience, and we don't have to experience it with them, but to be present in such a way that we can help them feel supported simply because we are listening and we care about the experience that they're having. I also think most of us don't recognize the support that we get and the support that we need, usually because we have the illusion that we're competent adults. But often we find the feeling of needing to fix people or fix the situation that people find themselves in. That's, I think, particularly true when trauma is afoot. Or we're, but fixing has a coercive quality. So it's more about power over than it is about power with. And often our suggestions to fix it, they may work in the short run, they may work temporarily, but they're not something that can be sustained. So I want you to be really careful of this, in particular, this concept, as you engage with people who need supports around trauma, because it's very tempting to fix in these situations. But what we really want to do is think about how can we develop supports that represent power with the person, helping the person make decisions that fit for their life and that represent that balance between what's important to them and what's important for them. And when we think about trauma and what we can do about it, whether it's in our practice person to person or for our system, we want to make sure that we always remember that we should expect trauma to be present. So assume trauma, the slide that we saw earlier, understand what its impacts are. So getting some training about, like, this is a good, brief training, but there may be some additional things you can avail yourself of that help you understand the short and long-term impacts of trauma and what to do with it when you see it, and what causes it, what happens in a person. And also make sure that we are offering treatment where it's necessary, because in not every traumatic experience that people have that requires support is going to require treatment as well, but sometimes it does. So there are trauma-focused psychotherapies that are highly recommended treatments for post-traumatic stress post-traumatic stress disorder. Trauma focused means that the treatment focuses on the memory of the traumatic event or the meaning of it for the person. And those treatments use a lot of different techniques to help process the traumatic experiences. And sometimes when you're seeing behaviors, when you're seeing someone who can't settle, who's really struggling to get past that, that's when you know that treatment for the PTSD is necessary. Often the kinds of supports that we're putting in when we're putting in person-centered plan, like through the discovery process, as we've been talking about, are enough. But for people who use services and supports, we want to make sure that if we're planning with them and trauma is a part of their experience or the triggers of trauma are causing them difficulty currently, have people who are professionals who have used treatments and are adapted treatments to them. I've mentioned Karen Harvey a couple of times. There aren't a ton of professionals out there who actually, if you're working with people who have IDD, who address trauma in people with IDD. That's an unusual kind of specialization. And the same is true for people with traumatic brain injury. A fair number of people who work with people with mental health concerns generally have some trauma training, but you need to be really specific about who is providing that support. And really think about offering treatment and support for people who use services and supports if it rises certainly to that level. Because as systems, what we're learning is we need education and training, and that's what this really is about. Mitigation, which we talked about a few slides back, and some treatment, and settings that reflect the balance between what's important to and important for the person, because that really can support the person to heal from that. Because making the changes that are needed in our systems that are from both a policy perspective and a practice perspective, so what we do in response to what we see, and developing the capacity to address trauma takes time, and we need to do that now. So if that's true, I have a final question for you about where you see the need to build capacity around providing services and supports or education for staff. Where do you see the need to change the way we address trauma, either in our daily work or in our systems in general? I'm going to just let you take that conversation in any direction you'd like to. If we're going to build hope for trauma-informed systems, trauma-informed person-centered plan, where do we see the need to build capacity? So I'll ask you to go back into your breakout rooms, and we don't have a terrible long time for this. I'm just going to give you 15 minutes together. And when you come back, I'll ask you to report out, please. So Debbie will open those rooms. They said they wanted generally to stay in the same rooms. And if you do not, if you want to hang back here with me and Debbie, we can put you in a different room. So no one will have to know that you defected. So we'll see you back in 15 minutes.
Hello.
Hi there, Victoria.
Hi.
Do you need some help getting into a different room?
Yes, I had problems with I had to get off my computer and get on my phone. I don't know what's going on.
Let's
Do you
see.
remember which room you were in earlier?
I'm sorry.
Do you remember which room you were in?
No,
There. Okay, I'm gonna assign you to a room then.
I think it was 4 or something.
Okay, I'll put you in 4. There you go.
Thanks for letting us know, Victoria.
You're welcome.
And I think Charles may actually be in a room, but he's got 2 connections.
Yeah, Charles has got like 3 or 4 actually. I think he shared his link. So people are, several people have got duplicated names. So I hope they.
Where do you see the need to build capacity?
And Marie, I don't know
She might be on a computer and a phone. That sometimes
I
happens.
think she is. I think she's on 2 different devices.
That's why I always try to stay quiet in the main room because
Yeah,
sometimes it bleeds
yeah,
over.
yeah.
Checking with Tamika, Charles, Sally, if you can hear me and you need help. Harriet, Katrina, Gina, Izella, Ali, and all right, it looks like we have everybody back. And I'm going to ask you to report out in just a minute. First, I'm going to put up my very fancy report out slide and take a look in chat. So a number of people were having a couple issues. I realize sometimes you get into a room and there are people who can't turn on their microphone because there's something going on around them. If you, just for your future reference, if that ever happens to you and you want to talk, come out and tell us and we'll put you somewhere else because we can tell who's talking and who's not. I just want to make sure people are getting the experience out of it that they need. That's not trainers saying you need to talk to one another. I get it. I totally have a job and people too. and I get what's going on in life. So we're just glad you're here. We're glad that you can take away some of this information and hopefully use it. I am curious though about developing capacity, where you think capacity needs to be built. If we could have just a brief report out before we call ourselves blessed for the rest of the day. Anybody got anything they would be willing to share with us based on your conversation?
Hi, this is Marsha again. So,
hey, Marsha.
Hi, how are you? So for our group, we talked about utilizing some of the person-centered planning tools that we currently have, using those tools to help us, using them in meetings when a person's in crisis to help as another avenue or resource to recognize when somebody may be having trauma informed. And that would be our person-centered approach by using some of the tools we already had. Then I'm going to ask Shane to join me, or Miss Karen to add in, or Teresa. Thank you.
Thank you. Shane, Karen, Teresa, you've been voluntold. Anything you want to add to that?
That was kind of the gist of the conversation. Yeah, I think Marsha said it pretty well.
Okay, excellent. Yeah, and I mean, that's kind of the point of this, right? Is just thinking about how the person-centered skills we're already using, that you're already familiar with and good at, and I've heard you reference them several times, can actually be used to help us be more trauma-informed. And it's really a simple matter of looking at asking questions in those 3 areas about who helps the person feel safe, what are the elements of safety, and what gives them a sense of power and control. Anybody else, any other groups would like to report out? You can put it in chat or you can turn on your microphone.
In our group, we tried to talk about trying to find out from the beginning when it comes to matching with someone with the staff that they work with, and try to how to ways to consider both ways to find out traumatic experiences from the staff as well as the person. So when we match them together, that we can kind of try to alleviate and decrease the amount of traumatic experience both for the staff as well as the person.
Okay, and sometimes we may not know. I think matching is one of the best determinants of quality of life for people. And we often, we're not asked to come to work and share what our trauma is. And I know you're not saying that, but we may not know that someone has had an experience, and we might be mixing people in a way that's pretty volatile if we're not careful. Anything else out there that you'd like to point out in terms of using trauma-informed supports, person-centered planning, and trauma-informed plans?
I think in our group, sorry, this is Comfort. In our group, we were speaking a little bit about kind of building the person's capacity to handle trauma. So we didn't really focus on the people that are working with them, but like the person themselves. So for example, if the person we already know what kind of trauma the person have experienced, then we can kind of build around that. So we were talking about kind of like practice. So if the person has a trauma or a fear of losing people, right? Because of COVID, that's very prevalent. We were just talking about how slowly kind of getting them acclimated to the idea that it's okay, and that they can build new relationships, or that helping them understand that they may have lost this person, but their other, supports are still there. So, their guardian or their mother or father or whoever is giving them support is still there, just to kind of anchor them a little before we try to introduce them to new people or new places, just to get that idea cemented before we try any new strategies. I think that's very important to kind of acknowledge the trauma first before trying to build strategies. Because if you, like you were saying, if you try to fix things before, trying to make sure the person is aware of the trauma, it's not going to work. So that's what we were just kind of focusing on in our group.
Thank you, Comfort. I was just working with a group last week. I won't say where, but they were telling a story about a woman who this is not related to the pandemic, but she lost someone that she lives with she lives in a home with 3 other women, and one of the women passed away. And a few weeks ago, she was shopping with a group, and she wouldn't get in the car, and she was crying heavily and kind of fussing with people when they were trying to encourage her to get in the car, and it was time to go, and she kept saying no, 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 no. And the nurse, who knows her pretty well, walked over to her and said, so and so, what's going on? This seems different than usual. And she said, I lost my friend. And so then she kind of started talking about the loss of the person that she lived with in the house. And, one of the things we forget is that sometimes when people have cognitive, something different in their cognition, it could be dementia, it could be a traumatic brain injury, it could be a developmental, cognitive developmental kind of issue. We often don't talk about grief and loss in the same way that we do with people who are neurotypical, and we end up missing opportunities to support them through that grief. And so this was someone who very desperately needed to not only be acknowledged for having lost someone, but for the pain she was in over that loss. And it was a simple matter of just being present with her, and after letting her just kind of ventilate that a little bit and cry a little bit about that person she lost, she got in the car and they went home. But, no support was in place prior to that. It's like the person died, and that was a fact of the situation, and no one talked about it. So they're really working hard at this organization to try to look at the places where they need to build those supports in, realizing that people may not be saying, I'm grieving because I lost my friend, but the behavior that they're displaying shows us that there's something going on there, and it's related to trauma. So thank you for that, Comfort. That was very helpful. All right, so I think we have reached the end of our time together. I could talk about this all day, but I know you've got other things to do. I do want to give you my contact information and just say thank you to you. If I can be of help to you, please don't hesitate to reach out. I want to mention again, Dr. Karen Harvey, you saw her referenced in the slides. You are getting these slides. They will be posted for you. So Dr. Van Horn has made sure that you always get the slides after the training. So please, take those. They have lots of information in them. And Karen Harvey's books are available as well. So if you have more need to understand trauma, particularly if you're working with people with disabilities, I mean, hers are good for anyone really, but I think particularly if you're working with people with disabilities, developmental disabilities, very, very helpful books to see. And you can find there are clips of her on YouTube as well. They're very helpful. And then the other 2 people that I mentioned are Bessel van der Kolk and Gabriel Mate. So if you're looking for deeper knowledge about that, that would be places to look. The other place to go, and I didn't put this website up here, I regret not doing this, but the Learning Community for Person-Centered Practices has all the person-centered tools. So please don't hesitate to check them out for if you're trying to remember your person-centered skills and you haven't looked at them in a while, that'd be a good place to go and just get refreshed on that. But for my purposes, I will say we are done for today. I appreciate so much having you here. Thank you for your attentiveness and for being willing to talk with one another. And I will see you, I hope, at the next training. I do see one question about incorporating post-trauma stress disorder versus post-traumatic growth and person-centered thinking. Post-traumatic growth fits very nicely with important to and strength. So that is a really good place to explore post-traumatic growth, is when we talk about what we like and admire about the person, about their strengths, the things that are important to them. And we'll certainly bring that out. Thank you so much, everyone. I hope you have a great rest of your day. I will see you when I see you. But I hope you'll come to our next training.